So in this video, let's study about iron deficiency anemia. Distribution of iron, etiology, factors affecting iron absorption, clinical features, lab investigations and treatment. Distribution of iron. When we consume any food items rich in iron, in that food items, iron may be in the form of Fe+3, that is ferric, and Fe+2, that is ferrous. So, iron gets absorbed into the enterocytes only when it is in the form of Fe+2 with the help of divalent metal transporter. It gets directly absorbed. But when it is in the form of Fe+3, it needs to be converted into the Fe+2. It is converted with the help of duodenal cytochrome B. At the basolateral border, Fe+2 enters into the plasma with the help of a transporter protein called ferroportin. Fe+2 binds to the ferroportin and enters into the plasma as Fe+2. So, for any cell to utilize it or to get it transported, it needs to be in the form of Fe+3. So again, Fe+2 is converted into Fe+3 with the help of ephestine or ceruloplasmin. This Fe+3 binds to transferrin. So whenever iron need to get transported in our body, it need to be bound to transferrin. So when iron binds with the transferrin to form iron transferrin complex, and it gets transported into different body parts like bone marrow for formation of RBCs and liver for storage of iron. Etiology of iron. So there are 4 causes. One is decreased intake. Second, increased demand. Third, impaired absorption, and chronic blood loss. So decreased intake. Decreased intake is seen in the cases of poor socioeconomic status and poor dentition, apathy and financial constraints. There might be chances of increased demand in the case of infancy, childhood, adolescence, pregnancy and lactation. Impaired absorption is seen in the cases of partial gastrectomy and malabsorption in the case of celiac disease, topical sprue and chronic diarrhea, steatorrhea. In these cases, impaired absorption is seen. And chronic blood loss. So in the case of increased menstruation, early onset of menarche and postmenopausal bleeding, there is chronic blood loss is seen. In the case of peptic ulcer diseases, hemorrhoids, hookworm infestations, ulcerative colitis, diverticulitis, GIT causes which may lead to chronic blood loss. In the cases of hematuria, hemoglobinuria, which are the causes of renal causes for chronic blood loss, and nosebleed called epistaxis, and lungs hemoptysis. These are the cases of chronic blood loss. So these might be the main 4 major causes which might lead to the iron deficiency anemia. So what are the factors affecting iron absorption? Factors affecting iron absorption. Factors which causes increased iron absorption are ascorbic acid, citric acid, amino acids and sugars in diet. Factors which causes decreases iron absorption are phytates of cereals, tannates, carbonates, oxalates, phosphates and drugs. Clinical feature. A patient presents with pallor, easy fatigability, dyspnea, shortness of breath, palpitations, angular stomatitis, cheilitis, koilonaikia and pica. So whenever we talk about iron deficiency anemia, Plummer-Vinson syndrome comes into picture. Plummer-Vinson syndrome is also known as Patterson-Kelly syndrome. And there is a triad in this Plummer-Vinson syndrome. It is esophageal webs, atrophic glossitis and microcytic hypochromic anemia. Lab investigations. We do complete blood picture and we see hemoglobin is decreased, RBC count decreased, total leukocyte count remains normal, platelet count is increased as there is a decreased RBC concentration, erythropoietin is increased as a reflux mechanism which may lead to increased formation of platelets. This is known as reactive thrombocytosis. RBC indices, MCV, MCH, MCHC all are decreased. Red cell distribution width is increased as in iron deficiency anemia. There are different sizes of RBCs is seen as RDW is nothing but the variation of RBC sizes in a peripheral smear. Sizes of RBC varies in this iron deficiency anemia, hence RDW is increased. Peripheral blood smear, there is microcytic hypochromic anemia, which is nothing but microcytic, small RBCs are seen. Hypochromic, greater than 2/3 of a central pallor is seen. Greater than 1/3 of central pallor is seen. And anisopoikilocytosis is nothing but RBCs with varied sizes and shapes. In iron studies, serum iron is decreased as it is iron deficiency, and serum ferritin is decreased. Ferritin is nothing but storage form of iron. When serum iron is decreased, storage form of iron is also utilized, and the storage forms also gets reduced, and total iron binding capacity is increased. Transparent saturation is decreased. Free erythrocyte porphyrin is increased, and bone marrow findings, marrow cellularity is increased. Thank you.